Okay, so this is my second attempt at the AT630 presentation, Peripheral and Spinal Mechanisms of Pain Control. So, similar introduction, a little bit better definition of pain now. So what is pain? The International Association for the Study of Pain says it's an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in such terms of damage. From Mirsky, 1964, originally quoted, and it's a pretty good definition. This is the most, I guess, widely used definition of pain. I did finally find it in a research study from back in 2007. I think in my first presentation, I also had this Lund et al. Dysfunction causing pain or pain causing dysfunction definition. I like both definitions. The dysfunction causing pain or pain causing dysfunction is up my alley with what I'm interested in with some of the SFMA, FMS type stuff. So I think that's why I like that definition. Now, the International Association for the Study of Pain definition is still good. It is very broad, though, because, well, to me, it is an emotional experience when you have pain. It can be associated with actual or potential tissue damage, but there's still something missing to me there. So some of this will look a little familiar, similar to my last presentation. The pain fibers, you have A delta and C fibers. A delta are large, slightly myelinated, fast fibers. They have or cause acute pain. So you touch a hot stove, you pull your finger back, this is the acute pain, immediate withdrawal. The C fibers are small, unmyelinated, and slow. These are more chronic pain type fibers. Now, this is what I usually look at or see in my patient population more so, are more acute chronic to chronically acute, if that makes sense, patients. I haven't seen, actually I did see one last week. A dancer did sprain their ankle. That was the first real acute, true acute injury I've seen all semester since probably last spring. So in my patient population, I deal a lot with the C fibers. Pain spasm, pain cycle. If muscle spasms cause pain, pain reflexively produces a muscle spasm. This is going to be a self-perpetuating cycle that might be established. Two different authors talked about this. I've seen this quite often in patients that they come in because they're in spasm or because they're in pain, and next thing you know, the spasm is there, their pain increases, the spasm keeps going, pain is still there. So how do we break that pain spasm pain cycle? We can do a couple different things, clinically, whether it's some kind of manual technique that we're learning right now or a more theoretical approach such as some of the stim variations of electrical stim, whether it's high volt or IFC or whatever it might be. In my clinical practice, I am not a big person on electrical modalities. I teach the class, but I like them, but to me there's so much theory and so much unproven that I just don't care for them. I'd rather use my hands, do something manual-wise to probably get a better result, if not similar result, probably better though. So this one study I've listed here, Cabedon 75, injected pain-producing substances into the body, caused it to spasm, found it produced spasm. So this guy, the article here, he was injecting very similar to a saline type chemical irritant that would cause a little bit of pain, but he found that it also produced spasm. So this is one of the first links that says, yes, different chemicals, that could be an ion channel later, but different types of mediators could cause pain, then therefore it could cause a spasm. A couple different types of pain. Visceral and superficial pain. Visceral pain can include orthopedic injuries such as sprain, fracture. What causes this pain? We're going to get there. Superficial pain would be a minor skin wound, something that we probably see clinically quite often. So I'm more interested in some of the visceral stuff that we'll get to here. My main theory that I talked about last time was the gait control theory of pain by Melzack, 65. This is pretty dated theory now. I think almost everybody that's gone for the 630 presentations has spoken about Melzack and this theory. The substantia gelatinosa modulates afferent patterns before they influence T cells. Afferent patterns activate selective brain processes that modulate a gate-like system. T cells activate neural mechanisms which are responsible for perception of pain. This is a pretty dated theory. Does a better theory exist? Yes, I think so. Now I think so. When I re-researched a lot of these things, even my first attempt at this, I found a couple different articles that I just didn't understand, I guess, and I just didn't take the time to actually sit and try to understand them. For the one article that I did happen upon this time and I like the best, Biomechanical Origin of Pain, proposing a new law of pain, 3-part series. I only talk about the first part really in this. So this is a new pain theory, the new law of pain as they describe it and as they term it, a new law of pain. So they say the origin of all pain is inflammation in the inflammatory response. All pain comes from a common origin. This could be or mean all pains, nociceptive neuropathic pain, acute chronic pain, all the different types of pain that we can think of that some of my classmates have spoken about, Dr. Nasipny has spoken about. They all come from a common origin. And all that origin is inflammation and inflammatory process. Makes sense to me to a point. That's a lot to bite off and say this is definitely why, or the best pain theory out there now, and this is why we have pain. It makes sense to me in my head, but I still think there's some things that we're missing here. So they also say abnormal spinal reflex transmission due to local injury. So you're almost stuck in a pain, spasm pain cycle. Causes the C fiber stimulation at the spinal cord, at the dorsal gray matter, dorsal horn of the gray matter. More inflammatory mediators are released, causing more pain in the spinal cord. So they're saying you sprain your ankle, you roll your ankle, you injure your ATF. Acute pain, it hurts, your spinal reflex goes to the spinal cord, the pain goes to the spinal cord, chemical mediators are released, more inflammatory mediators are released, substance P is a big one. Things that we don't want released causes more pain. Is there a way we can break that pain? Now, typically C fiber stimulation, like I said in the beginning, is chronic pain. So why would this be such a good example for an acute injury? Well, the article explains it and doesn't explain it to a point. For an acute injury, as soon as you injure the ligament, the tissue, the structure, whatever it might be, inflammation is going to occur, right? All the crap we don't want going into that joint, that ankle, that knee is going to go in there. We can ACE wrap it, we can ice it, we can do some things that we learn about in modalities and basic first aid to limit that swelling, but there's still things going on at a chemical level. We've probably all had patients that have sprained an ankle or injured themselves somehow that have absolutely no swelling but are a 10 out of 10 on the pain scale, and you can barely touch them because they're in so much pain, but they don't look like they're in pain because they have no bruising yet, they have no swelling, all the classically trained things that things that we're trained to look at. I think in my head this is why some of these people have pain, some of these patients have pain, and we can't necessarily see it, if that makes sense. I guess old school Ryan would have said, no, I have a patient with an ankle sprain. They're fine. There's no swelling. Yeah, they're a little tender, but you know what? It must be it's in their head. They're fine. Let's tape them up, have them go play. New school me, and I say new school since the summer, says, okay, well, just because I can't see it doesn't mean that there isn't anything going on. I think that's where this new law of pain hits the nail on the head. So how does chronic pain stop then? So with chronic pain, the C fibers are getting stimulated constantly. Gate control mechanism stays open. Inhibitory neurons dampen the spinal cord and hyperexcitability at the spinal cord level. Peripheral pain decreases by neurotransmitters GABA and enkephalon. Some other ones that I did not list. So, TENS unit. By using a TENS unit decreases pain, right? It stimulates the gate control mechanism, if you will, and can decrease pain. There's research out there that says it does it. We can do it easily in a modalities lab. If you slap the person on the arm hard enough and hit them hard enough, induce a pain, it will decrease their pain. So with the new pain control theory, the new law of pain, and a TENS unit, you can change the settings on a TENS unit, the waveform and whatnot, and that can help control chronic pain. It stimulates the gray matter and the dorsal horn of the spinal cord, and it stimulates more mediators to be released, such as enkephalon, GABA. I have up here in a couple slides another example of getting slapped on the wrist. We'll get to that here in a second. So I think that the chronic pain stops because, or gets improved, not necessarily stops, because of these C fibers, and if we can control the gate mechanism type idea clinically somehow, whether it's a manual therapy or electrical modality such as a TENS unit, and we decreased peripheral pain by increasing a GABA or an enkephalon or a neurotransmitter that we cannot see, and that's where I get into trouble sometimes, we can still decrease their pain. So I see this with a lot of the dancers I treat. They come in with knee pain for the past 6 weeks. Don't tell anybody, don't say anything, they'll take some ibuprofen, some pharmaceutical drugs, and next thing you know, they're coming to see me because they're still in pain. And I think that some of the positional release stuff is going to be good for this. So last time I did not talk about ion channels. I don't know why I didn't. I spoke with some of my coworkers here that teach neurobiology, and it makes complete sense why they should have been included. Ion channels should have been included. But anyways, to the point. Ion channels or gated channels can be charged by 3 different methods. You have your chemical, voltage, and mechanically gated channels. So your chemical channels are the GABA, the enkephalon, neurotransmitter type channels. Your voltage channels, such as an action potential, this is the change in membrane potential, usually going from negative 70 millivolts to positive 30 millivolts. And you have to hit the resting membrane potential of usually negative 50 to 55 millivolts in order for the channels to open up. Calcium comes in and all that fun stuff that you learned probably back in anatomy and physiology. And I had a teacher in exercise physiology last year, so that's a good reminder of the voltage channels. And the mechanically gated channels open due to physical deformation in the receptor. This is usually seen in touch and pressure. So we sprain an ankle. That causes pain, right? Chemical mediators go to it. Substance P, some things that we don't want go to the ATF, let's say, the lateral ankle. Membrane potential changes because there's action potentials being initiated due to pain. So the pain fibers, the nerve fibers in my ankle are getting stimulated because the voltage changes, -7 to +30 millivolts, causes an action potential to occur. Pain then goes to my spinal cord, ow, goes back to my foot, ankle, ow, this hurts. Who knew stepping on somebody's foot and rolling it would hurt? Rolling my foot would hurt. Swelling begins to set in. If it's a grade 2, grade 3 ankle sprain, maybe a lot of swelling. Once the gates open, the mechanical gates open due to physical deformation and receptor, all tissues have receptors on them. If my ATF, my anterior talofibular ligament receptors change, deform, because I just sprained my ankle, I just rolled my ankle and I stretched the fibers of my ATF, pressure from the swelling that is coming will come in and cause pain, right? This is athletic training 101. Swelling causes pain. First thing we want to do after an injury, decrease the swelling, and you will decrease their pain. You can do this many ways. Increase range of motion, whatever. You can do it many ways. But as soon as an injury happens, there's going to be swelling. So ideally, controlling that swelling first would be the best way to decrease the pain. But that can't always happen because in mechanically gated channels, ion channels, they're deformed. More chemical substances will go into the injured area, causing more pain. So, next slide here. Chemicals and neurotransmitters released after injury. Basic science that we don't understand, or did not understand this summer. I think Dr. Nasipny asked us this summer to explain the injury cycle, the initial injury, what happens when you sprain an ankle or injure a ligament, go through the chemical process. And I'm not very good at it, and I think that's my first attempt at this project was aimed to be very basic because I thought I knew a lot more than I did until this summer. So that's the whole chemical basis of ion channels. You have many neurotransmitters. They all are specialized, right, in different functions of the body. So GABA and enkephalon seem to be the two major ones that help, especially enkephalon, decrease the pain. So voltage, how fluids get in and out of a cell, right, can include neurotransmitters to a point, such as an action potential. So an action potential occurs, E-stim. A lot of the E-stim, electrical stim theories out there are based on voltage. High volt is classic. High volt, you have a positive and negative lead, polarity. You're supposedly changing ions, and if you leave it on for 45 minutes to an hour at a time, you can influence swelling to a point, and even chemical mediators to a point, theoretically. So, do I buy into that all the way? Not yet, because again, I can't see it, and I know that's a bad thing to say, but I guess I'm stubborn. But I still teach it like that. So E-stim, I have the question mark right next to that. If I use a high volt after an ankle sprain for 45 minutes on a patient, one, does my patient have 45 minutes between classes and whatever else that they need to do to decrease the swelling, to change the potential of a cell, to hopefully get some chemical mediators in that decreases the pain and swelling? Maybe, but probably not. If they're, especially the Division III level where it's focused on academics first and then athletics, they're usually, a lot of the patients I see are involved in many different clubs and many different things on campus that if they're scheduled to see me for an hour, that might be the only free hour they have throughout the day. So in reality, to me, putting on a high volt or another form of electric stim for 45 minutes to an hour isn't really realistic in my world. I don't know how many athletic trainers it would be, but if you look at different textbooks, different modalities books, that is the recommendation for a high volt for a acute injury to increase or decrease the chemical mediators to change the voltage of the cell, the ions of the cell, and actually get something out of putting stim on somebody. In reality, back in the day, I used to put stim on maybe 15, 20 minutes at a time. Is that doing anything? Maybe, but probably not. I think that's a big reason why I don't use stim anymore. So I hope these ion channels make sense. I definitely learned about these in anatomy physiology. You just kind of forget about them because it's been so long. You don't really think about it. So back to the slap on the wrist example. Peripheral pain. So slap on the wrist causes pain. If I slap somebody on the wrist, and we did this in my modalities lab this year, we took our only male subject, male student. Can't hit a girl, right? So we punched him in the calf until he had some pain and it hurt him. Pain. We hooked him up with a TENS unit. TENS unit is supposed to release enkephalon by sensory stimulation, and it decreases pain. So we measured his visual pain scale, did some other things with pain, and sure enough, it decreases pain. So this is slap on the wrist. Hit by a pitch in baseball, softball. What's the first thing you do is rub it. That's why. It releases enkephalon, decreases the pain. It blocks the A delta and C fiber signals to the T cells, which are located on the spinal cord, in the spinal cord. So massage can do this to a point as well, especially the sensory stimulation. If I go back a couple slides here, maybe, if my computer will let me. Massage and receptors right here, mechanically gated. Touch and pressure. So if we're doing different types of atherage or petrissage, different types of massage techniques, can that decrease pain? Well, it depends how hard you're pushing, right? The force. Some massage therapists cause you pain and you walk out of a massage and you're in more pain than you started with. Those aren't the type I like. So I spoke about this research article here as well, the Carr et al. 2011. In my last presentation, she examined 45 patients with lumbar discectomy in two groups. One had the TENS unit and a drug, and the other one just had a drug. TENS was administered 30 to 40 minutes each with a 3 to 4 hour rest window between. So analgesic consumption in the TENS group was lower, and visual analog scale was lower in the TENS and drug group than the drug group alone. So what does this really mean, though? So obviously physicians nowadays and people nowadays, we want the quick fix. Give me the drug, it'll cure up my infection, it'll make my pain decrease. But is that really true? Are we treating the pain, or are we treating the dysfunction that's causing the pain? I don't know. So I've spoken a lot about TENS, and this next article here, well, okay, so we'll get to spinal mechanisms first, and then I have an article after this, sorry. So spinal mechanisms of pain control. What spinal mechanisms can decrease pain? Can we use a mechanical device to alter A delta and C fiber pain? Yes, we can. We can do that by a mechanical device, would be a modality, even an ultrasound, theoretically, right? So we can do that by using a TENS unit, by using a high volt, by using different types of electrical modalities. Can we alter A delta and C fibers by drugs? Yes. Yes, yes, yes. Increase sensitivity in dorsal horn of the spinal cord, we can definitely do that. So this article I want to talk about was Borghi et al. 2010, phantom limb pain. So they examined 71 patients undergoing a lower extremity amputation. They used a catheter with pain medication during surgery and continued up to 9 days post-op. Patients were told once they have a 1 out of 5 on the pain scale in the phantom limb to remove the catheter. On average, about 62 days passed before the catheter was removed, but they still had phantom limb pain. And I still think, I think Jeremy talked about this because he talked about the neuromatrix, and I think somebody else in class had this article cited. And this might be due to dorsal horn of the spinal cord. There's still pain receptors going to the dorsal horn of the spinal cord. When that occurs, that spinal cord is still sending the signal to the brain saying, ow, my foot hurts, even though I don't have a foot. So how do we treat that? Well, Jeremy talked about the neural matrix, and I found some things in the neural matrix, and I was thoroughly confused. Jeremy did a freaking awesome job on explaining the neural matrix, and I tried to save his PowerPoint and his video, especially his video, to refer back on. So neural matrix, I'm leaving that to Jeremy because he did a phenomenal job at that. Manual therapies that we were introduced to, maybe in undergrad, but definitely this summer. Strain counter strain technique. Bailey 92 had a study about this muscle being stretched. Spindles are activated. Stretch reflex occurs. Putting a muscle in a relaxed position can decrease the stretch reflex and therefore decrease peripheral pain. Have you tried this? I have tried this. Tried this with my chronic cough. So I was going to have my wife do it, and then she ended up staying at work later one night for something, and then next day I came in, I had one of my students try it in clinical hours. And I have had some left ear issues my whole life. I had a little tumor in my left eardrum when I was 12, 13 years old, and had to have some my incus malleus stapes rebuilt back in the day, and I think that's why I have a chronic cough. It's always on my left side more than my right side, if that makes sense. And I noticed in palpation that my sternocleidomastoid is definitely tight. A lot tighter on my left side than my right side. So I had the one student try this on me. We did strain, counter strain, and positional release on my sternocleidomastoid. And I'd say about a half hour after I had the positional release and these manual therapies, I wasn't coughing. About 35 minutes in, I started coughing a little more, but I was also talking a little more. So I think there was something there. Last night, I'm laying in bed, I can't stop coughing. So what do? I palpate my sternocleidomastoid and I put myself into a relaxed position, and I'm holding it 90 seconds in bed. My head's supported by the pillow, and you know what? I stopped coughing, I fell asleep, and I haven't coughed yet today. So I don't know what the hell I did, if I actually did something or if it's in my mind. But I'm not coughing. So that's my strain counter strain thought. Positional release is thought to act on the nociceptive system by relaxation of surrounding tissues. So the new law of pain talks about it classifies all pain as the same right here. Origin of all pain is inflammation, inflammatory response. It does not matter, and I even highlighted it because I was surprised they said this. It does not matter about neuropathic pain, nociceptive pain, such as positional releases claims. Acute versus chronic pain does not matter. They lump all that in together. I've done a lot of positional release, and I'm beginning to understand it more and more now in the theory-wise. It may have an indirect effect on chemical mediators of inflammation. D'Ambrosio, 97. Great book. Have it in my lab right now. It's a great book. Tender points could be a somatic dysfunction. Releasing this tender point may affect multiple systems. So let me back up here. Chemical mediators. I talked about ion channels and chemicals. Have it right here. Ion channels, neurotransmitters released after an injury. The basic science crap that we don't like. It's not crap. That we don't like because we don't understand it as athletic trainers. Well, I need to go back and understand it better, because if I'm doing a positional release treatment on a dancer or a patient and it's affecting the chemical mediators of inflammation, and the new pain law says inflammation causes pain, I need to understand what the hell I'm doing. So releasing this tender point could affect multiple systems. I've noticed that. I had a dancer in last week with IT band pain. Traditional evaluation, with Obers and Nobles and all these tests that we do, and they're all positive, and she definitely has some tightness, I don't like using that term, over the IT band. Cat will yell at me for using tightness. I did positional release on her IT band. Her pain decreased from a 7 out of 10 to a 3 out of 10 right away. And we did it around the patella as well. I saw her yesterday at an open house for my campus, and she said that her calf is painful now. She could barely kneel down to the ground when she was doing a dance last night at rehearsal. And I'm thinking to myself, well, this could affect multiple body systems. The chemical mediators of inflammation. Her IT band didn't hurt to a point, but I've now caused pain in other areas of the body. So what am I doing? I've noticed this with a couple of dancers I've treated with positional release. I think there's something there with positional release. I'm trying to use it when I think it's appropriate, but not become dependent on it. I don't know if I'm doing well with that. I've been doing it a lot, but it's worked, and I like it. And now I think I understand it. If a chemical mediators of inflammation, if I am doing a positional release technique, does that release enkephalon? And that enkephalon decreases pain. Am I doing the same thing as a TENS unit? If it takes me 90 seconds to do it instead of 15, 20 minutes, 45 minutes for high volt, I want to do positional release. Why would I not want to do that? 90 seconds versus 45 minutes for maybe having some kind of change? I mean, I'm not the brightest bulb on the tree, I know, but that makes sense to me. Some of my 10 questions here. Can a manual technique therapy such as positional release help decrease chronic pain? I don't think we understand chronic pain that well. We'll get there. Which pain theory would positional release fit into? I think the new law of pain theory here that I'd like to post back to task stream once we clear out my old presentation. I want to post this article. Is there a way to measure the neurochemical makeup of pre and post pain of pre and post positional release? I think so. Not maybe at my university, because we're not a research intensive university and we don't have those tools here, but I think you could do that. Which pain theory is most accurate? Depends who you talk to. Depends who wrote it, right? Which is better, treating pain with a modality or manual therapy? I think of manual therapy all the way in my head. If I can place my hands on a patient, the placebo effect tells me they are going to feel better already. Now, in the real world, many of you, my classmates, probably can't do this a lot because your lack of time, perceived lack of time, whatever it might be, you guys are busy. You're seeing a whole football team plus basketball plus 4 other sports at once. I don't, and I like that. I went over to my wife's work, what was it, last week, Wednesday, for a basketball game, and I walked into the athletic training clinic, and I'm like, man, I don't know if I can do this anymore. I don't miss that craziness of having 50 people in a room trying to get treatment. I like my little bubble of dance and the performing arts that I have very individualized, hands-on time with every single one of my patients. I see a limited number of patients, yes, which might be an issue for AT640, hopefully not. But I can devote an hour, 2 hours at a time to a patient if I had to do that. And I think that's where the manual therapy comes in. I think physical therapists do a really good job at that. And I hate saying that because I know I have a lot of friends that are PTs, and we talked a lot about PT, AT relationships this summer, but PTs manage their time a lot better than us. So what manual therapies can we use for phantom limb pain that might translate into general patient population? Can we use a positional release, a strain counter strain technique where the amputation occurred? If it's below the knee or above the knee, can we do this on a quadriceps, a hamstring, to decrease a phantom limb pain? Are drugs the best route for decreasing pain, or can manual therapies be just as effective? I think manual therapies can be just as effective personally, but research out there might say something different. Research has shown promise in manual therapies in spinal cord patients. Ironetti, 2011. Can this translate into the general population? So it took some spinal cord patients, Ironetti and the authors on the study, and they did some manual techniques on them, manual therapies, to see if it decreased their pain, if they retained or regained any function. And some of them did. Now, obviously, I don't work in a spinal cord with spinal cord patients, and most athletic trainers don't. But it doesn't mean we can't do the research on it. It doesn't mean we can't be the ones helping lead the research into this. I think there's some promise in just some of these manual therapies, as I'm understanding more basic science with it, that could translate into the general population. In basic science research into nerve fibers, two B's, and their mechanisms of spinal cord needs to be studied further. So I have some references here, very similar references. I added a couple studies here. I hope that this presentation was a little bit more in depth within the ion channels, within this new law of pain that I came across and I really like. Please, if you have questions, email me, and yeah, thanks for watching my second attempt.